The paper I'm going to present today is about the possibility of treatment of hyperthyroidism. Many discoveries in science, technology, or other domains began with an eureka moment. For nuclear medicine, this moment was definitely in November 36. This happened when Dr. Saul Hertz, here in the image, asked Carl Compton, the president of MIT at that time, would iodine be made radioactive artificially? This moment can be considered the beginning of the theragnostic saga. Firstly, non-cyclotron iodine 128 was created at MIT by E. Roberts. Then iodine 131 was produced in cyclotron. Initial study on rabbits showed that hyperplastic glands retained more radioactive iodine than normal, and first ever radionuclide treatment was performed in 31 March 1941 with iodine 31. Let's now start with some definition in order to precisely differentiate between thyrotoxicosis, thyrotoxicosis with hyperthyroidism, and thyrotoxicosis without hyperthyroidism. Thyrotoxicosis is a condition in which there is an excessive amount of thyroid hormone due to endogenous or exogenous causes. It has multiple etiologies and potential therapies. And we have to distinguish between thyrotoxicosis with hyperthyroidism, which is characterized by excess thyroid hormone synthesized and secreted by the thyroid gland. It shows normal or high thyroid radioactive iodine uptake, and is named also true hyperthyroidism. And the thyrotoxicosis without hyperthyroidism, which means you have circulating hormone because of extra thyroidal sources like endogenous struma ovari, metastatic differentiated thyroid cancer, or exogenous factitious thyrotoxicosis, for example. It also can show up, this thyrotoxicosis, in the presence of the release of preformed or stored thyroid hormones into the circulation with low thyroid radioactive iodine uptake in the thyroid scan. It happens usually because of autoimmune processes or infections. True hyperthyroidism or endogenous hyperthyroidism usually accounts in 5 to 8% in Europe and 1 to 3% in USA, depending on the person who made the analysis, of course. Its prevalence increases with age and is more frequent in women. There is higher incidence of mild forms in iodine deficient areas. True hyperthyroidism is usually accounts because of Bezadov-Graves disease, which is diffuse disease, or because of a nodular thyroid disease, or less common because of thyrotropin-induced thyrotoxicosis and trophoblastic tumors. For Bezadov-Graves disease, the most common cause represent of thyrotoxicosis, it shows up mainly in areas with no iodine deficiency. Is an autoimmune disease with genetic predisposition, accounting more often in women. Psychological factors are usually incriminating, and smoking and some others. And of course, it's high production of thyroid hormone because of high production of stimulation of TSH because of the TRAP antibodies. Nodular thyroid disease is represented by toxic multinodular goiter, in which prevalence increases with age, or toxic adenoma, Plummer disease. It is more prevalent in older population in area with iodine deficiency. It accounts in autonomous hormone production, which can be caused by somatic activating mutations of genes regulating thyroid growth and hormone synthesis. Thyrotoxicosis affects virtually and influence almost every tissue and organ system in the body. If not treated or bad treated, it will complicate with weight loss, osteoporosis, atrial fibrillation, embolic events, muscle weakness, tremor, neuropsychiatric symptoms, even cardiovascular collapse and death. The most often we find ophthalmopathy, 25% of cases, present with ophthalmopathy. It has special importance in severe forms where should be treated in specialized clinics, these ophthalmopathies. It also have some signs and many signs of which are showing increased adrenergic stimulation like tachycardia and anxiety. And these signs are often pathognomonic for the thyroid pathology. Selection of appropriate treatment is based on precise diagnosis and is of course influenced by coexisting medical condition and of the patient preference. In the diagnostic algorithm, depending on author and on the journal studied, for example, this article in Lancet said that for definitive diagnosis, we should use either a thyroid scan or thyroid ultrasound, depending on preferences. On the other side, a thyroid scan is telling us by a guideline of American Thyroid Association. They said that a thyroid scan should be obtained if clinical presentation suggests a nodular disease, a plumber or toxic multinodular goiter. Scintigraphy, in European Thyroid Association guideline, scintigraphy of the thyroid is suggested when thyroid nodularity coexists with hyperthyroidism and prior to radioiodine therapy. Thyroid scan can be made with iodine 123 or 131 or with technetium. The uptake is performed together with the scan. It will show diffuse uptake in Graves' disease or focal uptake in adenoma, multiple area of focal increased and suppressed uptake in multinodular goiter. Special attention should be, and we have to be very careful on Graves' disease, which is associated with non-toxic nodular goiter with positive TRAB and nodular ultrasound, like in this case, or heterogeneous uptake images. We have some option of hyperthyroidism treatment, antithyroid medication, radioactive iodine, and surgery. We are going to choose between all the three of these in function of the clinical situation, of logistic, of the cost, time to recovery, which is expected, or potential side effects. These are all factors which are going to influence our decision, our therapeutic decision. And of course, we are going to talk to patient and to see which one is most appropriate for him or for her. For Graves' disease, we can use radioactive iodine. This is preferred method in USA with a slight decrease, of course, in preferences in recent years. Antithyroid medication is the preferred approach outside USA, in Latin America or Europe or Japan, and of course, surgery for some form of the disease. As I mentioned before, we have to be very careful if we have Graves' disease with coexisting thyroid nodules. And we have to take into account that cancer probability in less disease and in Graves' disease is less than 2% in these patients. However, hypofunctioning nodule of 1 or 1.5 centimeter have definitely indication of fine needle aspiration. Other guidelines for thyroid nodules and differentiated thyroid cancer is also published. So probably we should follow the guideline for this particular situation. There are some indications which can favor one or other modality, and we can orient in function of this clinical situation. For example, radioactive iodine is indicated if the patient has comorbidities and the surgical risk is too high. Is also indicated in patients that have previous neck surgery or external radiation therapy, or if there are contraindications to antithyroid use or failure of antithyroid treatment. And one of the approach in Europe, for example, is failure of antithyroid treatment for a long time indicate automatically or sometimes radioactive iodine therapy or surgery. For antithyroid disease, antithyroid treatment are usually indicated if there is a high likelihood of remission. For example, if we have a patient with mild disease or small goiter or no titer or low titer of TRAP antibodies, or pregnancy, or in elderly where comorbidities involve a high surgical risk. Or, for example, we can prefer this method in case of inability of patient to follow radiation safety regulation, for example, in nursing homes or something like this. And in moderate to severe active graves ophthalmopathy this is also an indication almost categorical for antithyroid. Antithyroid drugs are indicated as a first-line treatment of Graves' disease, particularly in younger subjects, and for short-term treatment of Graves' disease before radiation therapy or thyroidectomy. Surgery is definitely indicated in large goiter, which involve compression. If we suspect thyroid malignancy or thyroid malignancy is demonstrated, if there are large thyroid nodules with low function on thyroid scan, if it is also hyperparathyroidism associated pathology requiring surgery, or in moderate to severe active Graves' ophthalmopathy. Hyperthyroidism due to nodular disease, toxic multinodular goiter, or autonomous toxic nodule. According to the guideline of American Thyroid Association, we can rely on the first two, because in this case they recommend long-term antithyroid only in selected cases. Surgery, for example, they recommend it, and they said that the risk of treatment failure is, of course, less than 1% following near total and total thyroidectomy, and euthyroidism is achieved within days after surgery. It has better results in large compressive goiters, but this also have something to do with logistic, because if you do not have a very specialized surgeon in the area, it's not indicated. It is indicated because of this indication of near total and total thyroidectomy. It is better to have a very specialized surgeon to do this kind of operation. For the radioiodine therapy, there is 20% risk of retreatment in toxic nodular goiter. The response rate is 50 to 60% by 3 months and 80% by 6 months, according to this research. And it is considered that overall the success rate of radioiodine therapy, success means definitive hypothyroidism or euthyroidism, is 81.1% in toxic multinodular goiter patients. For the thyroid adenoma, surgery is also very much recommended because the risk of treatment failure is very low. Why it is this failure? It is because usually they do surgical resection, lobectomy, or isthmusectomy. It's not nearly total thyroidectomy. So that's why probably this risk. Hypothyroidism will show up in 2 to 3% following lobectomy for a thyroid adenoma, lower after isthmusectomy if isthmic localization of the nodule. There are potential complications associated to all thyroid surgery, like hypoparathyroidism or recurrent laryngeal nerve lesions, which of course can be diminished if the surgeon is highly specialized. For the thyroid adenoma, we have in option the radioiodine therapy, which can be preferred in some situations. The risk of persistent hyperthyroidism in thyroid adenoma treated with radioiodine is 6 to 18%, depending on the research. There are 3 to 5.5% risk of recurrent hyperthyroidism, and there are 75% response rate by 3 months and 89% rate by 1 year following radioiodine therapy, according to the literature. Hypothyroidism has a progressive prevalence from 7% at 1 year to 60% at 20 years, which is, I think, a marker of the success of the therapy. Overall, it is estimated that the success rate of radioiodine therapy in thyroid adenoma is 93.7% in thyroid adenoma patient. There are, of course, there were attempts of alternative or future therapies like ethanol ablation or radiofrequency ablation, but unfortunately, there is insufficient evidence for recommendation of this method to be continuously used on a routinely basis. There are also ongoing clinical and preclinical trials which evaluate novel therapies that could address pathogenic mechanism of this disease, like monoclonal antibodies or immunomodulatory peptides and so on. We are going to see if these clinical trials are going to bring an alternative, viable alternative to what we have at present. At present, both American and European guidelines affirm lack of sufficient prospective randomized trials to compare efficacy and cost-effectiveness of antithyroid drugs, radioiodine, or surgery. Guidelines make recommendation. Final decision is definitely taken after carefully judging the clinical situation of any particular patient. Evidence-based algorithms are definitely required based on scientific prospective work. Thank you very, very much for your attention and enjoy the session.